Hi,
Morning, how
I'm
you
Mary
doing?
Moore.
Show
How
the
are you
equipment.
doing?
Pleasure, my pleasure.
Lovely to meet you. So yeah, so this is the adult version of the bed, and it's really very modern. It's a much smaller. It fits into areas because always in an ICU room, you know, there's not a lot of room. So this has a lot more. It gives a lot less real estate. The nurses really like that. So it gives all sorts of information as well, including, especially you do a lot of training here at Kings County. So if anyone doesn't understand your mode, one of the fellows or residents, by merely holding the thing, it will tell you about how the mode works and what should be said. So that really comes in very handy. It has different views on it as well. So you can look at different things and different aspects. I have this loops view on right now because a lot of the doctors look like they look at pre-medication, post-medication, and they can keep track of all that. In addition, the nurses really like this one because when they leave the room, it's really hard to see the numbers from outside. So they can actually move the screen. It has full movability. It can go up and down for their height, and they can put this towards the window so they can see what's going on with the patient at all times. If an alarm goes off, the block where the alarm comes from, if it's a high pressure or if the respiratory rate's high, that will light up. As well, the doctors really, a lot of times we can't always convey information to the doctors. We can write down numbers, we can tell them what happened, but there's nothing like a picture to tell you the true story, right? So we have here, I just did that, we have here under media, I took a picture of a before and after loop. Now this means nothing to you, but to the doctors, this is gold. They'll be able to see how the medication's working. So I can do, this is how the patient's numbers were beforehand, and this is how their graphics were beforehand. It's kind of like looking at an EKG, but by respiratory. And then they can look that the blue was beforehand and the white's after. So they can really gather information on this. So also, they can trend all the information that they want. Depending on what's wrong with the patient, we look at different things. So with this, you know, trends are really great. I didn't just start the ventilator, so there's not a lot of lines across it. But trends are really great, but you know, they're kind of, you know, you feel like you're doing this forever and you can't find it. So the doctors can come here and easily, and respiratory, of course, because they're really the experts on the machine, are the respiratory therapists. But they can easily, this works like an iPad, as I told you. So depending on what they want to look at, they drag into place. All this information is stored no matter what, but so that it works for them and for what they're doing, they can drag this information into place, and those will be the first things you see. So it's very easy to get information out. It's very easy to set up. This is all very easy to clean, which is very important these days with the Joint Commission. And it gives you tons of information for the doctors.
This is wonderful. This is remarkable. The size.
Yeah, the size, and it's nice.
Very
It's
neat,
everything-
very nice.
Everything's, you know,
And the
touch
function
screen.
also, the features that.
Yeah, it has a
remarkable.
lot of really great features in it. They're coming down. Did you bring my end-tidal CO2?
No.
Yeah. Are they coming?
David, how you doing? David, get it. Thanks for coming. See all the great work that you're.
Oh, that's wonderful. Wonderful.
Because of you, we were able to achieve this. 20 new ventilators.
Listen, what you are doing in comparison of what I'm doing is nothing.
Gotcha.
This is only my way to encourage you and to say that, oh guys, you know what? I love what you're doing and keep on doing that.
No, this is great.
This is great.
For our neonatal
I can show you. I can see it.
you can see it's totally different.
Yeah, it looks different. This machine was designed exclusively for use on neonatal patients and pediatric patients, as opposed to the U, which can ventilate any patient population, neonate, pediatric, or adult. But neonatologists don't like ventilators to go back and forth between adult units and the NICU, because babies, for the first 6 months, they're pretty much existing on their mom's immune system. So they're very vulnerable. So these machines will stay in the NICU only. All right, they do have some application for pediatric patients. That machine over there, as I said, can ventilate any patient. Now, what we're showing you here is a couple of key features of the ventilator. Number one, this is called the proximal sensor. And all you need to know about that is this is for the very, very small babies, maybe 500 grams, 750 grams. And what this does is this allows the baby to trigger the machine here. So the idea is every breath they attempt to take, they get. So there's no wasted effort. Because when a baby attempts to take a breath and they don't get anything in return, what happens is they're burning up kilocalories, and they need those kilocalories to grow. We're going to help the babies grow. So that was the whole idea behind this. The other thing you see here is another key differentiator. Without going into much detail, it's called NAVA. NAVA is neurally adjusted ventilatory assist. What it does, a lot of times, the machine is not working with the baby. The baby's doing one thing, the machine's doing something else. What NAVA does is allow the baby to control the ventilator using the electrical signal from their diaphragm.
Yeah,
this is what we-
remarkable to see that the machine try to interact with the electricity.
Absolutely.
That's remarkable.
Because you know the signal starts, as you know, in the breathing center, travels via the phrenic nerve. Once it gets to the diaphragm and the action potential changes, the sodium-potassium pump is activated, the ventilator actually
Going back
goes
to my
into the-
physiology, right? That's right. My biochemistry.
Now, we use this
That's
is just
remarkable.
a
That's-
simulation. But what this represents is the actual contraction of the baby's diaphragm, the strength of the contraction. So for example, when you go shopping, if you're like most guys, if you're like me, and you come home with 10 bags of groceries, you want to get all 10 bags in the house at the same time, okay? Instead of making 2 trips. And your body says, okay, this idiot's up at it again, okay? He's trying to bring more bags in than he should be. What happens is the signal from my brain, because my metabolic level is increasing, the output of the signal from my brain increases. And it gives me a bigger breath. It causes my diaphragm to have a stronger contraction, okay? And that's what this represents. This peak represents when the diaphragm's contracting, the electrical activity is produced, and this trough you see is when the diaphragm's at rest. So it's kind of like depolarization of the heart and repolarization of the heart. And we can pretty much tell,
Knows his stuff, huh?
we can tell from that signal whether we're under or over ventilating the baby. If you're under ventilating the baby, then what's going to happen is this signal is going to be very large. So the baby's brain is saying, you know, I got to get what I need from someplace, so it's getting it from its brain, but it's working too hard. So then they would adjust the level to bring that down. Okay, and the same thing is true in reverse. If you're giving the baby more than they need, that signal is going to be tiny. So this helps them titrate the settings on the machine to what the baby needs. And the other thing it does is it puts the ventilator in sync with the baby. So when when the brain gets to the diaphragm, as I said before, the machine actually cycles into the breath. It also allows the baby to control the size of the breath. So if the baby's metabolic activity increases and they need a bigger breath, they're going to get it. All right, and also that we use the electrical activity of the baby's diaphragm to turn the breath off. So baby controls the start of the breath, size of the breath, and the end of the breath. And the whole idea behind that, again, is so that, you see this up here? That represents a wasted effort, meaning that the baby wanted a breath, ventilator didn't see that, so it didn't deliver. But that's when you're burning those kilocalories, right? So this simulator shows that. And this is, again, what we use for physicians like yourself to show them how this technology works. The other thing that's nice, if you look here where it says PBW, we can actually put in the baby's predicted body weight. And for a baby, their birth weight and predicted body weight are one and the same. So we put that in, and what that does is we can look here and see how many mLs per kg we're giving the baby. Am I being too clinical? Yes? The idea behind this is if one of the neonatologists only wants the baby to receive a certain volume, they can look at this and see, based on my settings, the baby's getting too much. So they can adjust the settings so that the volume the baby gets is less. It's consistent with their philosophy, their clinical ventilating philosophy. When in fact, we used that, we put a baby on the machine last week and use that to fine-tune the settings. So pretty much everything else. Mary talked to you about being able to do screen captures. She talked to you about flow volume loops. She showed you all the views. The other thing, and I don't know if Mary mentioned this.
I didn't show the family view.
Okay, yes. This one, family view, is designed to try and minimize the family's anxiety. Because I'm talking to the nurses in the unit. Now, all those babies in the unit are on a monitor. And that monitor is spitting out all kinds of numbers. And the family's asking, what does this mean? What does that mean? Then they look at the ventilator and they see all the numbers, they see the waveforms, they start asking questions about that. So the whole idea behind this is to minimize their anxiety. And to get out of it, you just touch it.
See.
Okay. So everything is designed to make life a little bit easier. That's Thomas. Anyway, another guest just arrived.
Okay.
Questions? You see that little set of lungs there? That's how you know, that's how the physician will know, that's how the nurse will know, that's how the respiratory therapist will know that the baby is actually triggering the machine. Every time the baby triggers, you see that. So, pretty interesting piece of equipment. Plus, if for some reason there's a loss of power, the machine will go into battery operation and continue to ventilate the baby.
For how long?
It depends. That depends on how many batteries you have. The machine can accommodate as many as 6 batteries. So if you have 6 batteries, then it can actually ventilate the baby for 300 minutes. Okay, they come with 2. Usually with 2, if the machine's plugged in and the battery's fully charged, you probably get about 75 minutes out. And since they don't use these machines to transport babies within the hospital, it's not of any consequence. Because we have other things in these bays. You call this the plug-and-play section. Those are the batteries. That's the simulator, and that's for the proximal sensor. That makes it much easier for the baby to trigger the vent. We can do something called volume-targeted ventilation. Okay, most neonatologists use pressure-targeted ventilation, but if they wanted to target a specific volume and deliver that to the baby, this machine is capable of doing that as well. We call it leak compensation. You see this says 5% there? This machine will compensate for leaks up to 60% and still guarantee that the baby gets the volume, the amount of air that's set. That's pretty much it.
You did a good job.
That's very good.
Let me tell
Thank
you,
you.
that's what we do in the medical field. We got to learn from them. Whenever there's a new technology, no treatment. And let me ask you one thing. This is
Yes,
so
sir.
wonderful. And it really, the size, compact, and the different features. That's remarkable. We know that now they're trying to make a new approach to medicine.
Absolutely.
So, in case, let's say, for example, this hospital get the data, and if we want to communicate with
the
another
EMR?
doctor or another hospital to transfer, the information that we have collected from this machine about one of child.
You mean electronically, or if you want to
Yes.
consult with another physician?
Exactly.
Well,
Is that
the machine is set up so that, and I'm not answering the question you asked, I'm just giving you more information.
Okay.
It's set up to communicate with the EMR,
Okay.
the electronic medical record. But if you look underneath here, Mary showed you how to do screen captures. If you look underneath here, there's a USB port.
Okay.
So I can export data from that USB port. I can put it into a PowerPoint format, and then I can send it to a physician in another hospital. Okay, because the RTs have been taught not to put any patient data in there, so there's no HIPAA violation. The only thing they would put in is a medical record number. And nobody's gonna remember what medical record number is associated with what patient. So in essence, the answer to your question is yes, there is a way of communicating with another physician, maybe getting a consult from them. And they don't necessarily have to be in a hospital across the city. They could be in a hospital across the country. You know, as
And the
long as
machines will also interface with our electronic medical record.
Okay. Technology is about softwares, right?
That's right.
Softwares and computers.
That's correct.
In case the system is down, any alternative? What is the backup plan?
Nice question.
If there's gonna be a glitch
Yes.
in the software,
Uh-huh.
the ventilator will tell you that. It will give you an alarm. It's something we call the technical error code. The other thing you need to understand is that between patients, a test is performed on the machine called the pre-use check. The pre-use check guarantees that the ventilator is functioning within our specified ranges so that they know before they put it on a patient that it's safe. If there was an issue with software, for example, during that pre-use check is when they're gonna find that out. So it would never actually be put on the patient. But if it's on the patient already and there's an issue, you're gonna get an alarm. So the system will tell you there's a problem. Safety first,
Safety first.
safety first.
That's great. Anyway, you did a good job. Thank you,
Thank you, sir.
for the class.
Appreciate that.
And
Anytime.
I'm really excited to see, the use of this machine on the patient. this is not the end. There's got much more to do, okay?
Absolutely,
But
absolutely.
you're doing a wonderful job. I'm saying, you know what I was thinking about when I was reflecting on the ventilators? People, the patient, and critical needs. If you cannot breathe, what's going on? You know that.
Right.
That's
right.
it.
Right.
But when we keep people alive, you know, help them to breathe and the machine to breathe for them, this is bring life back. You see what I'm saying?
Sure.
And this is so important, and I think this is a very important piece.
We're going to be able to ventilate patients and identify faster with the weaning process, initiate weaning faster. We can ventilate them better. As you heard, the machine is synchronized to the patient better. So therefore, with that, it's going to help us to be able to get them off the ventilators even faster.
And I guess one of the challenges that I know it's not just all respiratory, what we have with
The VA ventilator associated
VA,
events,
right.
yes. So that's also going to help us to reduce those, because the sooner we're able to get the patients off of mechanical ventilation, the better it is. Then we can prevent our ventilator associated events. So that's the goal. And we've put in a lot of initiatives to really help us to reduce those numbers, and we've done preventing patients from getting pneumonia. So we're really working diligently to make sure that we're reducing our numbers and that our numbers consistently remain low.